Good afternoon, everybody. This is Marie Mays Voorhees from the Minnesota Department of Health, and it is my great pleasure to kick off this webinar related to Minnesota's healthcare home legislative evaluation study. And I have the pleasure of doing the overview, and then I'll introduce our investigator team from the University of Minnesota. So I guess the first thing I just want to do is just to make sure that everyone knows that the healthcare home implementation is really part of this overall Minnesota health reform package. And when we think of it, our main focus is around care redesign, and that focus around patient and family-centered care, connections with the community, and really looking at patient-centered, coordinated team-based structure. Many of the healthcare homes have implemented their care coordination models. I think what's really important to know, though, is that the healthcare home is also very focused around improving access. There's a prevention requirement, and if we didn't have our HIT and quality measurement systems in place, that infrastructure, we wouldn't be able to do the systems, the clinical systems redesign and the community systems redesign without those. So it's really part of a package of reforms in Minnesota, and as we move forward, one of the next steps, there's many, many reforms, but one of the next steps around patient-centered coordinated care is the Minnesota Accountable Health Model through the State Innovation Model Grant. Now, we've had really great success and participation in Minnesota, and the hard work of clinics you're going to see and their partners is really paying off related to looking at our triple aim outcomes. Currently we have, actually I think we have 324 certified healthcare homes, but about 42% of the primary care clinics in Minnesota are a certified healthcare home, and our goal is to really certify about 67 to 70% of the healthcare homes by of the primary care clinics that are eligible for certification by the end of 2015. And you'll see that those healthcare homes are serving 3.3 million Minnesotans. And so we know that when we redesign our systems, while we might be focusing initially on those patients with complex and chronic conditions, that systems improvements impact the care delivery and the patient-centeredness for everybody. And this is just a little graph to show you our journey, and you'll see that we are actually right on course related to the number of certified healthcare homes that we projected that we would continue to certify, and we know that we have many, many, well over 50 to 100 clinic systems and clinics that are in the queue and actively working their certification right now and their practice transformation. I think one of the things that we did in Minnesota is we really, through our community partnerships and our strong public-private partnership, we really put together a recipe on what we thought in Minnesota is transformational. And that's what's so exciting about our evaluation, is that we're now really getting to start to see, well, does the approach that Minnesota put in place around implementing the patient-centered healthcare home really work? And so we really focused on strong patient and family participation and focused on patient and family-centered care at all levels. We, as a community, developed standards for certification that all types of clinics can achieve. So we have certified clinics that are solo clinicians all the way up to very large systems. We have specialty clinics, HIV clinics, and rural clinics. We have clinics that are virtual clinics. So we really have a flexible model related to the clinics that we certify that are providing those key elements around primary care. We've had support from our statewide learning collaborative, and we over and over hear that the learning collaborative has been very supportive to transformation. We have a payment methodology that we've developed, and while the payment methodology doesn't always work the way everyone would like, and we certainly have things we have to improve related to making having critical mass, one key thing is that it did start us thinking from the very beginning about the tier levels and the risks of patients and how we should think about implementing that new thinking in our clinics. Integration of community partnerships is just critical. I hear over and over, well, we couldn't have done it if we didn't have our community partners, and of course, outcomes measurement with accountability. So the last thing on this list, but not least, is really our evaluation. And so we're going to move forward and talk about our evaluation. This is our contact information, and so if you're new to healthcare homes or you're thinking about certification, we do have our nursing team that are located around the state, as well as our team here in St. Paul that can support you in our journey. So it's my pleasure to, why won't this move forward? Okay, so it's my pleasure to introduce our evaluation team from the University of Minnesota. And present on this webinar is Doug Hooley, who is our co-principal investigator, along with Michael Finch, our other co-principal investigator, as well as Lindsay Grood, who is our research coordinator, and Jessica Zeglin, who is our research fellow. And without their extreme dedication, we wouldn't have this amazing evaluation report in such a small time. I'd also like to thank our healthcare home team, and especially Monica Hemming, who has been our evaluation coordinator at the Department of Health. Okay, Doug, your turn.
I'm switching you over now, Doug.
Thanks, Monica. We're really excited to be here and to be able to present today. What we're going to talk about is we're going to first provide a quick background on from our perspective, the HCH initiative and how we fit into this whole story of the healthcare homes. And it started in 2008 with health reform in Minnesota aimed at 3 reform goals: healthier communities, better healthcare, and lower costs. And during that health reform, and Marie's already mentioned this, there were some really important things the state did early on that laid a strong foundation for this healthcare home evaluation, as well as laying a strong foundation for implementing healthcare homes. One is, and we're going to come back to later, is the statewide state quality measurement and reporting system that captures clinical quality measures. Minnesota Community Measurement works with all the clinics in the state to obtain that data, assemble that data, and manage that data, verify it, make sure it's good. It assures statewide reporting on quality and outcomes measures. What's really important from our perspective, this started in 2009, a year before the Healthcare Home Initiative started, so we knew what was happening before the first clinics were certified. There's also state efforts on e-health, e-prescribing, EHR, interoperability that provide a foundation for healthcare homes. And finally, there was a development of an HCH healthcare home certification standards and process, which was built on strong stakeholder involvement and buy-in throughout the whole community. And I'm going to come back to this because this is a really important point, because it assures that healthcare homes meet standards, that you know that a healthcare home is a healthcare home, which from an evaluation perspective is a critical thing that we want to know. And I think Minnesota is in the forefront of doing that. So a healthcare home is not a nursing home or home healthcare or a restrictive network or a service that only benefits people with complex conditions, but it's clinical care redesigned. It's population health management. It's patient-centered integrated care focus. It is the foundation and building block that will be moving to the accountable care organizations that Marie mentioned. And finally, it's going to be involving and moving into more community partnerships that build healthy communities, as well as a clinical setting. It has a future community focus. So it's welcoming, relationship-based, organized, unrestricted, and comprehensive. So in other words, all the providers working with you will be aware of the information they need to know. It will be coordinated. It will help you choose people who best help patients choose people who best meet their needs, as well as assisting patients who need assistance with social services and other things to organize those so their health is better. Right now, at the end of 2012, we are completing our first phase, stage 1 evaluation. Clinics started being certified in July of 2010, was the first one, and at the end of 2012, we had 221 clinics certified as healthcare homes. This report's going to discuss those 221 clinics. So our first evaluation was to respond to specific Minnesota legislative requests for an evaluation of demographics, quality, use of payment, disparities, and estimated costs. And so our primary goal here was to answer the questions that the legislature posed to us for the phase 1 evaluation. What we do is we show a comparison between healthcare home clinics and non-healthcare home comparison clinics on measures of access, quality, and cost. All the clinics we're examining are healthcare home eligible clinics, that is, primary care clinics. We're focusing on a real-world evaluation of an initiative that is open to all healthcare home eligible clinics, primary care clinics. We are watching in 2010, there were around 45 to 50 clinics certified. We have had an increasing number of clinics certified over time, increasing number of patients being served by healthcare homes. So we're trying to examine how healthcare homes work in a real-world environment of developing a program rather than in an environment of we have a few clinics that are developing healthcare homes and we're examining. This is a real-world rollout of healthcare homes at the statewide level. We're also focusing on the actual quality and experience and dollars spent by the Medicaid program and also for the quality for all patients in the state that are served by HCH-eligible clinics. The future evaluation we'll come back to. We're going to be going much more deeply into these evaluations to examine the impact and the causal effects of the HCH initiative. How much of an effect did the HCH initiative have on access, quality, and cost? This initial analysis just examines differences between similar clinics by HCH certification. In the future, we'll risk adjust cost and quality, and we'll also take into account the changing mix of clinics and patients served by HCHs. Okay. A stylized logic model that is guiding our whole analysis is the first step in implementing healthcare homes is clinics have to make the decision that they want to participate in the healthcare home initiative. And that's due to incentives such as payment, public reporting, professional reputation, clinical outcomes, clinics feeling that this is an important way to provide better care to their patients and moving forward to participate. Another thing that affects participation is your existing capability, the presence of electronic health records, the presence of a learning organization. And finally, the final factor are social networks, the health systems they're part of that provide the infrastructure and the assistance in moving forward to participation. That's the first decision. After the first, okay, so the participation reasons include a lot of things like professional identity, improved professional outcomes, reputation, and other factors. Then transformation starts. Once a clinic has decided to transform, they get involved in learning collaboratives. They learn about the certification, the fidelity standards. They receive coaching on implementing healthcare home in their clinic. That leads to a step where they certify, implement the healthcare home, and they certify. And the important point here that I want to bring up, I can't emphasize too much, is certification tells you whether healthcare home was really implemented. So if you don't know whether something's really implemented, you cannot evaluate whether or not it works. And finally, various clinic culture, incentives, and the way you actually make healthcare home work results in better patient experience, better access, improved population health cost and savings. So that's the overall model guiding us. We have questions, eventually, what causes clinics to participate? How do clinics go about transforming? And then how does the new healthcare home, and how do you implement it, how does that affect outcomes that are important to us? So the evaluation report provides some key findings on the HCH model, provider enrollee demographics, care quality, payment disparities, and initial estimates of costs and cost savings. Finally, we'll talk about limitations and next steps. The evaluation findings, I've mentioned this. The fidelity and certification is a core feature of this process, and it supports the rest of the evaluation. Our provider demographics, this mirrors some of Marie's earlier slides, that what we see is the continued growth according to plan of the total number of clinics certified. And as you see, on a monthly basis, the number of clinics varies because a clinic becomes certified as part of an application group. And some application groups are large sets of clinics, some are smaller sets of clinics, and they come in and they get certified at various times. Even though how many certified in any given month might be a little bit lumpy, there's a nice continuous smooth increase in the number of clinics certified. That is matched with a number of patients and enrollees served by HCH certified clinics. Again, what we have is that this is a diagram of December 2012, that HCHs tended to be in urban areas. Initially, that sort of matches the population density of the state. What we also found on some of our analysis is that larger clinics, clinics with higher care quality, and clinics who are serving more Minnesota healthcare plan patients are more likely to become certified. The provider demographics show that most of the HCH providers, or nearly half of them, are family medicine and pediatricians. And also, most of the providers within healthcare homes are what we normally associate with primary care providers: family medicine, internal medicine, and pediatrics. Enrolling demographics shows that the number and the percent of Medicaid enrollees in certified clinics has increased over time. We did some analyses of which types of enrollees are more likely to be in HCH clinics, and we found that enrollees that are in the higher healthcare home payment tiers are more likely to be in an HCH, as are persons of colors, individuals who speak a primary language other than English, and have lower levels of educational attainment. So in other words, healthcare homes appear to be serving the populations targeted by the Healthcare Home Initiative, enrollees from historically disadvantaged populations and enrollees with more complex medical conditions. If we look at the measure of comparing HCHs and non-HCHs for the proportions of patients from racial and ethnic minorities, if you notice, non-HCHs have 65.2. In non-HCHs, there are 65.2% white, whereas it's only 49.8% in HCHs. And so in HCHs, you see a much larger proportion of non-white populations, people of color. So the HCHs are reaching those individuals. And the same holds true for individuals who speak a language other than English. We assess the care quality using the statewide quality reporting measurement system. This is data collected and managed. The collection process is managed by Minnesota Community Measurement. SQUIRMS requires all physician clinics in Minnesota to submit data on quality measures. And now the strength of the SQRMS measures is they are quality reporting that includes commercial, Medicare, Minnesota healthcare plan, uninsured, and self-pay patients. So these quality analyses are not just about Medicaid, they're about all the patients and all the population in Minnesota. Our quality measures included optimal and average diabetes care, and I'll describe the difference between those, vascular care, depression, asthma care, and colorectal cancer screening. Okay, so this is a brief description of the SQRMS data, and it's about 750 healthcare home eligible clinics, and we're comparing with 221 certified clinics. The number of clinics in each analysis varies by which clinics were submitting data Minnesota community measurement. Now, we assess two types of measures we're going to talk about. The optimal care measures, also called the Grand Slam, is whether or not a patient met all the component measures for care. For example, diabetes optimal care is met when a patient has HbA1c levels below 8, cholesterol levels below 100, blood pressure below 140/90, no tobacco use, and also aspirin use if you have a patient has a comorbidity of ischemic. So the only way a clinic is measured as meeting a performance target there is if all of those are true. The average care measures calculates the percentage of the number of measures that are met. So a diabetes average care is 80% when a patient achieves all their goals, assuming the patient doesn't have vascular disease, achieves all their goals except tobacco use. We use the average care measures because research shows that these tend to be much more reliable measures than optimal measures. What we found, and this is for all patients, commercial, Medicaid, Medicare, Minnesota healthcare plans, everybody, is that HCHs had better care quality than non-HCHs. The only difference was that there's no difference at remission at 6 months, depression remission at 6 months. The depression follow-up at 6 months is an interesting measure because it can be interpreted as a continuity of care measure, that patients who have greater continuity of care would be more likely to be followed up at 6 months. So that is an indirect way of observing that HCHs may be having an effect on continuity of care, which is a desired component of the healthcare home model. We can also see in this diagram the optimal diabetes care for 2010 to 2012 and optimal vascular care that, again, HCHs, which are in the goldish bars, are higher performance measures, and the results were similar for average care. We are asked to assess the HCH payment method experience, how clinics were dealing with implementing the payment experience, and we did that by doing 3 surveys of healthcare homes. One, we asked healthcare homes about their decisions and preparations made by their clinic to bill for monthly care coordination services. Then we asked clinics about what types of financial analyses they conducted prior to becoming certified to see if they did a cost-benefit analysis, whether that informed their decision about becoming certified, and also the importance of care coordination payments for implementing and sustaining healthcare homes. Finally, we asked clinics about their tiering practices, so that how do you, when your patient presents, when you're submitting a bill, how do you assign the tier to the patient for submitting a bill with the appropriate tier level? And we had fairly high survey response rates in all the categories. And so we represented over 90% of the clinics. Now, this included in cases both clinics responding individually and health systems responding for their standard practices for the clinics in their health system. The key findings were collecting care coordination payments is important, but financial incentives were not a primary driver of HCH participation. And also, obtaining payment from Medicaid was easier than obtaining payment from Medicare, managed care, and commercial insurers. And Marie, I think, alluded to this a little bit earlier. And some HCHs have reported having cost increases associated with operating and starting up a healthcare home, because you have to employ care coordinators who have to transform the system. Most HCH clinics told us that the Minnesota Care Coordination Tier Assignment Tool is adequate for current use and could be improved and some improvements may be useful. And if we look at our payment here, we have the number of care coordination claims through the end of 2012 is increasing over time. Okay, and you can also see the breakout between Tier 1 through Tier 4. Tier 4 might not look like a very large proportion, but most of the patients, there are very few patients relatively in Tier 4 categories. So, in our analyses of disparity in care that we presented a little bit earlier, that the part of that was the HCHs are serving enrollees with higher severity medical conditions, disadvantaged populations, populations of color, populations that the legislation was targeted at. So compared to populations of color in non-certified clinics, populations of color in healthcare homes used fewer emergency department and ambulatory surgery services, had fewer evaluation and management visits, used more professional services and more hospital outpatient services. And we're going to be going, in our future analyses, we're going to be examining how the mix of services vary between HCHs and non-HCHs. Our analysis of cost and cost savings showed that in the first year, 2010, HCHs had a higher cost per Medicaid enrollee attributed to an HCH-eligible clinic. In 2010, the difference between HCHs and non-HCHs decreased. By 2012. HCHs were seen to have a much lower cost than non-HCHs. Now, the lines on the graph are important because the bars show you the average per member per year cost. The lines show you the number of enrollees attributed to HCH and HCH eligible clinics. And in 2012, there was a significant improvement in the number of enrollees we could attribute to HCH clinics. And this is due to two things. One, through having information about which physicians are associated with which clinics from the HCH certification database, and similar information from the State Quality Reporting Measurement System on physician association with clinics. So in 2013 and 14, as we move forward, we hope that we will get continued improvements in attribution, which will give us better analyses of cost differences. Overall, our estimates, if you look over the period 2010 to 2012, our analyses showed that the HCHs had 9.2% lower costs for a Medicaid enrollee attributed to an HCH clinic. So the preliminary analyses show that healthcare homes have lower costs. So our conclusion is basically healthcare homes are associated with greater access to care, especially for populations of color and disadvantaged populations, greater quality of care, and lower healthcare costs. So in other words, they're working the way that it was hoped that they would work. Limitations of this initial evaluation: it's a beginning phase. Clinic and enrollee participation is increasing over time. The initial participation rates meant that we had low numbers of evaluation. And the other difficulty here is that clinics were self-selecting into participating, and so some of the differences may be due to which clinics decided to participate initially, who's decided to participate later. The other issue with an early analysis is Healthcare home effects may take a while to emerge. A clinic starts transforming to a healthcare home when they apply to be a healthcare home. When they're certified, they reach certain standards, but the transformation process at the clinic level continues as the clinic continues to learn how to implement the care coordination and the patient-centered integrated care they need to operate at the processes they need to produce the outcomes they want. And also, over time, you also have to work with the enrollees and the patients so that their health behaviors change. So there may be lags between the implementation and when you observe the cost reductions and the quality improvement. The measurement of costs and resource use depends on attributing enrollees to clinics using medical claims data. This is a difficult process, and we're working on that to make sure that we get fairly good specific measures. It is improving over time because of the data that is being collected by the HCH initiative and by the data that is coming from Minnesota Community Measurement associated with the SQRMS quality reporting measures. So our next steps are to do an interim evaluation to Minnesota Department of Health in 2014, a final evaluation to Minnesota State Legislature in 2015, and as we continue, we're going to be including more data as it becomes available, for example, Medicare. We're going to estimate the effect of the HCH initiative on clinic transformation and therefore on changes in access, cost, and quality. So we're going to be, rather than just saying our HCH is different than non-HCHs, we're going to be asking the question, does becoming an HCH affect quality, access, and cost? We're going to be adding measures to examine the HCH initiative on the patient experience through the PCMH CG-CAPS measure. We're going to be digging a lot deeper into disparities and how HCH effects differ by enrollee populations and subgroups such as groups based on socioeconomic status, rural, ethnic and urban, urban and rural, FQHCs versus other types of clinics. So we're going to dig a lot more into understanding that. We're going to be working on improving the evaluation methods such as attribution, risk adjustment, and causal modeling, okay? And we're going to also be digging further into understanding how and for whom a healthcare home works best. In recent conversation we've had with a number of people, and there's been a recent Journal of American Medical Association article on medical homes that has just come out that has received a lot of visibility. And it was a study of 32 intervention clinics compared to 29 matched clinics in Pennsylvania over a 3-year period from 2008 to 2011. And what they were examining was clinics that were becoming and transforming to be a healthcare home with clinics that were not transforming. Now, so in other words, these clinics were not NCQA certified as healthcare homes until the end of the study. So this is a transformation study, not a full-blown operation of the healthcare home study. And they studied a cohort of continuously enrolled patients over the study period, and they used claims data for assessing quality and costs, and they had to attribute that data to clinics by visit patterns. They did very sophisticated and very excellent methods such as propensity score matching and difference analyses to be able to assess causal effects. What they found was limited improvements in quality and no reductions in healthcare utilization. We think that we have initial results that are different and I think may play out a little bit different once we dig further into our analyses. We have all patients served by HCH certified clinics, 224 now. At the end of 2013, it'll be over 300. And so we have many more clinics for comparison. These clinics are also in a real-world environment, not a selected group, but of clinics stepping forward to implement healthcare homes. An important point on the model here is all the clinics we're studying are certified as healthcare homes through site visits at the start of the study period, so that we're not just examining the transformation. We're studying how certification as a healthcare home is related to access, quality, and cost. Measures, a difference that we have is the SQRMS quality measures are self-reported by clinics for the patients they say are their patients. That means attribution is not imputed through an algorithm, but this is the clinic saying, here's who we serve and here's the quality of the care, and there are also clinical quality measures. Cost and disparities are analyzed using attribution. Our methods are not as sophisticated as the Friedberg et al. Article. We're moving to implement methods like that. But our preliminary analyses show that healthcare homes are associated with improved access for disadvantaged populations, higher quality, and lower costs. And so it's going to be, as we move forward and dig deeper into the analyses, we'll be able to figure out, be able to compare ourselves more fully with the Friedberg et al. But right now we're optimistic and with our early findings, and think that there might be stronger, more positive effects than ones he's reported by the earlier article. Now, so the comparison to the phase 1 evaluation, in the future, we'll have many more clinics. Again, we'll know that the clinics meet core criteria for being a medical home. We'll have more quality data on more measures to compare so we can know, and that will improve the reliability of the measurement. And then we'll also be digging much deeper into examining transformation, causal effects, and all sorts of other aspects of the healthcare home initiative. And this is information on our report and where it is available and who to contact if you have questions. Thank you. And can I open the floor for questions?
And thank you so much, Doug, and to your team for that great work. And we're really interested in audience's questions. So you can either type them into the chat, or you can go ahead, your phones are unmuted, and you could go ahead and ask the questions directly. I think you have to unmute.
Hello.
Hello.
Hi, I have a question. This is Kristen Godfrey-Welters calling from HCMC. And Marie, I believe I had a conversation with you before, was asking about in the future the state being able to pull data for specific organizations, or could HCMC utilize this data to show impact and results and outcomes of our specific healthcare home clinics?
Kristen, that's something that we have to think about related to how we could do that in the future, but I do think that there is value in thinking about how could we provide clinic-specific data to the clinic.
Okay. I think that would be helpful, because I think this report was very helpful organizationally, and then the question is always, well, how do we compare, or what is our specific data, and that can be challenging to have the resources to do this kind of study on a smaller level.
Okay, this is a question from one of the people in the audience, and it says, from a business perspective, as healthcare homes are serving a higher population of Medicaid patients, is it a concern of healthcare home participating clinics of sustainability? Or are there different reimbursement rates by being part of a healthcare home?
That's really,
I suppose I'll take, do you want me to take a crack at that first, Doug, or do you want to?
no, I'll let you take a crack at sustainability is a key issue here, and the financing was important, and I know that from what you've learned so far, that payment from commercial self-insured employers is really an important issue here.
That's right. The state is very interested in implementing and understanding how to do healthcare home payment for the broader critical mass. But the one thing we also know is that the payment methodology that's been developed is really a stepping stone, and while we want to continue to provide providers for costs, we also know that that won't take care of it. It's not the sustainable payment. And so total cost of care and ACO-like kinds of payments are really the way we're going to need to move forward. And what we're seeing in the literature and what we're seeing in Minnesota is that having a strong implemented primary care system with good patient-centered coordinated systems is going to be essential to having successful ACO and total cost of care like payment. So payment is happening in so many different ways right now, and we are really going to have to better understand how it's going to be sustainable. And as many of you probably know, Medicaid is currently doing a study that's associated with the Minnesota Accountable Health Model. Their a lot of terminology here. They're integrated health partnerships, which are the ACO-like models for Medicaid. And those are currently in place. You can go out to the Department of Human Services and see their website, and to learn more about those. So a lot of moving parts around payment that's going to be essential related to sustainability. Doug, I have a question for you.
Sure.
Thinking back related to the providers and that provider slide that we were looking at for family medicine and pediatrics, could you just give us some idea related to how that compares to the number of pediatricians or family medicine doctors that are in the state? I know that's something that you looked at in your report.
I'm going to ask Mike to handle that because he's the one that dug into that data.
Yeah, because I'm sitting here going, I don't remember.
I know we looked at it and we discussed it a lot.
I know on the primary care physicians, primary care physicians, it was quite substantial. Jessica's helping me out by finding the numbers. Thank you.
Mike, we're having problems hearing you.
I'm sorry, I'm moving over. I'm getting closer. Let me read the chart so I get it right here. Looks like we had about 45% of all family medicine docs were in the healthcare homes in the state, and about 43% of the pediatricians are in healthcare homes. And that's based off the 2011 licensure data.
Okay. All right, great.
Yeah, that'll get much more in 2013, but we don't have that licensure data yet for the new year.
Okay, so I think that's really helpful information to know that we're nearing, critical mass related to our providers, and not only that, but in lots and lots and lots of our healthcare homes, we have residency programs, we have medical students, we have nursing students, we have dietitian students, social workers, and so we have a whole opportunity here to really be training our workforce in working in a coordinated team approach. And I know Mac Barrett at the university and lots of the other residency programs are really engaged in training residents around the coordinated team, care delivery team approach. We would certainly be happy to take additional questions from the audience. We still see that there are about 36 of you on the call, or you could certainly type in a question. Your questions help us to figure out how to continue to move forward.
Or if you would like to email us questions at a later time, we're more than happy to answer, and we do like to hear all your thoughts because they help us do a better job.
I think the other thing is that if you have comments as well, it doesn't necessarily have to be a question, but we would be happy to take your comments about the report itself. And I really appreciated, Kristen, that you shared that from your organization perspective that the report was helpful and valuable to your organization.
Or if you have specific things that you would like to see. It is probably the case that we haven't thought of everything that one could ask. And so questions that you have that we could ask, we would really like to receive, of the data, we would really like to receive those so we do a better evaluation. Our goal is in 2015 to have an evaluation product that answers your questions and answers the state's questions.
Okay. Well, it looks like it's Friday afternoon and we're ready to wrap up. And I want to thank the university as well as our partners at MDH and DHS. The report, the legislative report, and the healthcare home evaluation report are available at the website that is displayed on your screen, as well as on the MDH website, which is right below there. And if you have other questions related to the evaluation, you can certainly email us at health.healthcarehomes at that email address that was just up there. That one, health.healthcarehomes@state.mn.us. And so thank you very much, everybody, for participating in our webinar on the Healthcare Home Legislative Report. Have a terrific weekend.
Thank you.
Thank you.